My name is Maria Grant, and my project is the Opioid Epidemic, Curving the Line. Prescription drug abuse continues to be a growing problem in the United States. This addiction is often overlooked because it is happening with legal drugs that are frequently prescribed by doctors. The alarming rates of overdoses and deaths caused by legal prescription drugs should no longer be overlooked. Two methods of health belief model theories that I will be using are the socio-ecological model and the social cognitive theory. I will be using the socio-ecological model as a form of prevention by starting where it begins, with prescribing doctors, pharmaceutical companies, and chronic pain patients. The social cognitive theory will be used as treatment for those who are already taking opioid prescriptions, those who are abusing it, and those who have overdosed. The purpose of this intervention is to not only increase awareness about the dangers of prescribing opioids, but also treat those who have already fallen victims to the dangers of these medications. With this intervention, I hope to drastically decrease how many opioids are being prescribed on a day-to-day basis and instead begin to utilize alternative pain management methods. By bringing awareness to this issue in the beginning, it decreases the likelihood of someone abusing opioids. By also helping those who already have an issue with opioid use, it will decrease the death rates related to opioid prescriptions. It is important that everyone realizes how serious this issue is and how they all play an important role in combating this issue. First thing I want to talk about is what is an epidemic and what is an opioid. According to Merriam-Webster, an epidemic is defined as two things: an outbreak of disease that spreads quickly and affects many individuals at the same time, an example, an outbreak of epidemic disease, or an outbreak or product of sudden rapid spread, growth, or development, an example, an epidemic of bankruptcies. An opioid is a natural, semi-synthetic, or synthetic substance that typically binds to the same cell receptors as opium and produces a similar narcotic effect, such as sedation, pain relief, slowed breathing, and euphoria. In my project, I will focus more so on prescription opioids. Prescription opioids can be prescribed by doctors to treat moderate to severe pain, but can also have serious risks and side effects. Opioids are typically classified into Schedule 1, 2, 3, 4, and 5 controlled substances. Substances are categorized from high potential for abuse and severe psychological and physical dependence to low potential for abuse and low psychological and physical dependence. Schedule 1 controlled substances have currently no accepted medical use in the United States, and there is no accepted safety for use under medical supervision. These drugs include heroin, peyote, ecstasy, marijuana. As of recently in some states and cities, it is being used medically. Schedule 2 drugs include hydromorphone, methadone, oxycodone, most commonly known as Percocet, fentanyl, hydrocodone, most commonly known as Vicodin, Adderalls. Schedule 3 drugs include products containing not more than 90 milligrams of codeine per dosage unit. Some examples are Tylenol with codeine, buprenorphine, also known as Suboxone. Schedule 4 drugs include Xanax, Soma, Klonopin, Valium, and Ativan. Schedule 5 drugs include cough preparations containing not more than 200 milligrams of codeine per 100 mLs or per 100 grams, which are like your Robitussin AC and your promethazine with codeine. So what's the problem? Doctors are prescribing these medications and pharmacies are filling them, so it must be okay. Well, the problem is, in 2018, 67,367 drug overdoses occurred in the United States. Opioids, mainly synthetic opioids other than methadone, are currently the main driver of drug overdose deaths. 2/3 of opioid-involved overdose deaths involve synthetic drugs. The graph at the bottom shows rates of overdose deaths associated with 3 categories of opioids as well as all opioids. The rise in opioid overdose deaths can be outlined in 3 distinct waves. First wave began with increased prescribing of opioids in the 1990s, with overdose deaths involving prescription opioids, natural, semi-synthetic, and methadone, increasing since at least 1999. Second wave began in 2010, with rapid increases in overdose involving heroin. Third wave began in 2013, with significant increases in overdose deaths involving illicitly or lawlessly and illegitimately manufactured fentanyl, The market for illicitly manufactured fentanyl continues to change, and it can be found in combination with heroin, counterfeit pills, and cocaine. Most common drugs involved in prescription opioid overdose deaths include methadone, oxycodone, such as OxyContin, hydrocodone, such as Vicodin. In 8% of drug overdose deaths in 2018, no specific drug was listed on the death certificate. In many deaths, multiple drugs are present, and it is difficult to identify which drug or drugs caused the death. For example, heroin or prescription drug when they are both present. When looking at overdose deaths from prescriptions, the CDC analyzes the following: natural opioids, pain medications like morphine and codeine; semi-synthetic opioids, pain medications like oxycodone; methadone, a synthetic opioid used to treat pain, but it can also be provided through treating programs to treat opioid disorders. Current information reported about overdose deaths does not distinguish pharmaceutical fentanyl from illegally made fentanyl. In order to account for increases in illicitly manufactured fentanyl, the CDC Injury Center separates synthetic opioids, other than methadone, from prescription opioid death calculations. According to Science Daily from the University of California, for opioid medications prescribed, 44% of average patients were prescribed from doctors' offices in outpatient settings, 26% from dental offices and other outpatient settings, 16% from emergency departments, 14% from inpatient hospital settings. In 2017, almost 57 million American patients had at least one prescription for opioids filled or refilled. The average number of opioid prescriptions was a 3-to-4 ratio, and the average day supply was 18. Taking opioids for longer periods of time or in higher doses increases the risk of addiction, overdose, and death. As many as 1 in 4 patients receiving long-term opioid therapy in a primary care setting struggle with opioid addiction. About 21 to 29% of patients prescribed opioids for chronic pain misuse them. Between 8 to 12% develop an opioid disorder. An estimated 4 to 6% who misuse prescription opioids transition to heroin. And about 80% of people who use heroin first misuse prescription opioids. So how exactly is opioid abuse treated? It is treated in an outpatient therapy basis or an inpatient program. These programs are dedicated to treatment of people with addiction. Many of these programs use medications to help patients transition from physical dependence. Medications used to treat opioid abuse include methadone, which is also considered a Schedule II drug. When administered properly, is included in treatment with counseling and is always provided in a clinical setting. When used to treat opioid disorder, it helps relieve withdrawal and address cravings. Buprenorphine, which is also considered a Schedule III prescription, also relieves opioid cravings without giving the same high as other opioid drugs. This medication is prescribed by many physicians from an office setting. It is typically a daily dose. It's placed under the tongue and also can be delivered as a once-a-month injection or through thin tubes that are inserted under the skin and last about 6 months. These medications activate opioid receptors in the body that support cravings and are effective and similar in safety and side effects and typically used for maintenance treatments. They can also be used to taper patients off of opioids. Patients who are highly motivated and have good social support have a tendency to do better with these therapies. Naltrexone is a very different medicine and doesn't turn the opioid receptor on, but instead blocks the euphoric sedative effects of opioids. A patient's system must be completely free of all opioids before beginning naltrexone. It can be taken orally or as a once-a-month injection. As you can see, the methadone and buprenorphine, they're scheduled drugs, which means that these prescriptions can also become addictive if the patient isn't properly tapered off of them. So how are we treating addiction with something else that can become an addiction? So how are these controlled substances being monitored? The U.S. Department of Drug Enforcement Administration, also known as the DEA, is responsible for the enforcement of the Controlled Substance Act, which includes the regulation of DEA numbers and controlled pharmaceuticals. Doctors who want to be able to prescribe must obtain a DEA registration number. Doctors and pharmacies are able to utilize a PDMP, a prescription drug monitoring program, to see when, where, what, and how many opioid schedule controlled substances patients are receiving. When a doctor prescribes a controlled substance, they must enter the patient's information into the state's PDMP, as well as check patient's history, which helps in the regulation of these drugs. By the doctors and pharmacies working together, it helps with not overprescribing controlled substances and not combining any controlled substances that might be a health risk to these patients. So how can we curb the line in this epidemic? To reverse this epidemic, we need to improve the way we treat pain. We must prevent abuse, addiction, and overdose before they start. We need to treat those that have already fallen victim to the dangers of these opioid prescriptions. I have chosen 2 health models and/or theories that I believe will serve in curbing the line in decreasing the number of overdoses, addiction, and deaths related to prescription opioids. In this intervention, I will use the socio-ecological model as prevention to combat the issue before it begins, and the social cognitive theory to help those who are already taking prescription opioids, those who are abusing them, and those who have overdosed. The CDC defines the socio-ecological model as a framework for prevention. The socio-ecological model emphasizes multiple levels of influence such as individual, relationship, community, and societal, and the idea that behavior both shape and are shaped by the social environment. The principles of the socio-ecological model are consistent with those of the social cognitive theory concept, which suggests that creating an environment accepting to change is important to make it easier to adapt healthy behaviors, which brings us to a second form of intervention, social cognitive theory. It explains human behavior in terms of a 3-way dynamic reciprocal model in which personal factors, environmental influences, and behavior continually interact. The social cognitive theory incorporates concepts and processes from cognitive, behavioristic, and emotional models of behavior change, so it can be readily applied to counseling, interventions for disease prevention, and management. A basic premise is that the people learn not only through their own experiences, but also by observing the actions of others and results of those actions. Our ultimate goal is to stop addiction before it begins. The overlapping rings in the model illustrate how factors at one level influence factors at another level. It allows us to understand the range of factors that put people at risk for addiction or protect them from experiencing it. The first ring, which is your individual, it identifies biological and personal history factors that increase the likelihood of abusing opioids and becoming addicted. Your second level, which is your relationship, examines close relationships that may increase the risk of exposure to prescription opioid use. A person's closest social circle, peers, partners, and family members that influence their behavior and contributes to their experience. The third level, which is your community, explores the settings such as schools, workplaces, doctors' offices, and neighborhoods in which social relationships occur and seek to identify the characteristics of these settings that are associated with becoming addicted to prescription opioids. And your last ring is the societal factor. It helps create a climate in which prescription opioid use is encouraged or inhibited. These factors include social and cultural norms that support prescription opioid usage. Other large societal factors include the health, economic, educational, and social policies that help maintain economic or social inequalities between these groups. So for this as an intervention, I plan to create a program which visits these neighborhoods in rural areas and visits these doctors' offices and these pharmacies, and it shows them the facts. It shows them how high the death rates are for opioid abuse and overdoses, and I hope to prevent them or decrease how many prescriptions they are prescribing. So, and then meeting with family members as well as friends, their workplaces, just getting the word out there that this is a serious matter and it can be prevented. The ultimate goal with this theory is to help assist those and mentor those who are suffering from opioid addiction before it escalates to something more severe. Using this theory, I will reach out to patients in rehab facilities as well as those that end up in hospitals because of an overdose. The most important variable here is that people have already experienced some of the dangers of opioids and will hopefully be more willing to change and accept assistance. By looking at someone's personal factors, for example, lifestyles, occupations, their age, their behaviors, as in are they optimistic, are they pessimistic, are they trusting, and some of their environmental influences, for example, their internal environmental influences like hormones, externals, like an effect of a certain drug. One can come up with a plan to help with the treatment of opioid abuse and addiction. The key constructs of this theory that are relevant to health behavior change interventions include observational learning, reinforcement, self-control, self-efficacy, self-efficacy, or a person's confidence in his or her ability to take action and to persist in that action despite any obstacles or challenges, is especially important for influencing health behavior change. Changes in the environment, the examples of role models and reinforcements, can be used to promote healthier behavior. Implementing this theory at rehabilitation centers, I believe, will increase the success rate and decrease the relapse rate. By using these two health models and theories, my expected outcomes are that I would like to see a decrease in the number of opioid prescriptions, a decrease in number of patients on opioid prescriptions, a decrease on number of overdoses due to opioid prescriptions, and a decrease of deaths due to opioid prescriptions. I would like to see an increase of awareness of potential dangers of opioid prescriptions, an increase of alternative pain management options, increased rehabilitation center admission success rates with no relapses. So with the findings of my research, I hope to strengthen opioid prescriptions to where a patient goes through many forms of pain management before even considering prescribing an opioid. Many patients go through many medications because they are not strong enough or they stop working and they need something stronger. An opioid should be your last resort. This is an important issue that affects everyone. Therefore, we need everyone to come together and fight this together. There are many doctors who should also be held accountable for overprescribing or prescribing opioids when they weren't absolutely necessary. This issue isn't going to go away from one day to another. It will take much longer than that. I hope I have raised some form of awareness about this issue and how it's serious and how it's not being taken serious, because a lot of people think that just because a doctor is prescribing this medication, it's okay for you to be on it. It's okay for you to need it. When in reality, it's really not okay, and many people do not see that. Thank you.